might be measuring that aren't relevant, or that we might be measuring and trying to treat or trying to intervene upon when it may not be necessary. So that's the why. Is now that we're at this point of, actually it's just the why is, how do we make healthcare suck less? How do, and Dave and I were talking about this morning, but how do we capture information about people that really is relevant in driving why they access healthcare? The how, to me now, is how do we operationalize that from either patient-reported outcomes, or capturing this information, engaging with patients when they're not in our healthcare system, but outside of their healthcare system. And that gets to digital health, is now we're all tracking information, whether we know it or not. I didn't realize my phone was tracking everything about me until somebody started to show me their analytics on their phone, and you could see when I was walking across campus or when I'd gone for a run, those sorts of things. I didn't even know were on my phone, but I run with my phone. I do everything with my phone. We're very close. So we're now tracking information, and it's seamless. It's passive, right? Patient-reported outcomes, those questionnaires, they're a burden to everybody, right? If I have to think about my disease every time I'm answering the question, that may have an unintended consequence of me having to think about my disease. If you can just take information from me about how I'm moving and have that project what is going well or not going well, then we're kind of advancing where we were 10 years ago with our paper. Actually, even before that, there's a researcher here who used to do it with a pager, and it would go off every time somebody had to fill out their paper. So we've gone from this archaic process of being able to capture information now to this new rapidly changing place where we can capture information at any given point. How do we start to now leverage that information to individualize the care we provide, or to individualize the care we provide in a way that doesn't cause undue burden to the healthcare system, to the providers, and to the patients themselves? So somebody had asked about what my research arc is, and I feel like it's continuing to evolve with technology. If you would have asked me what my research arc was 10, 15 years ago, before I think iPhones even existed, I think I was still on like the old flip phone version where I didn't even foresee this ability to capture data. It would have been, how can we just better understand our patients outside the clinical metrics we use? So that's the simple where I started. And now it's how do we capture this information, be it patient reported or patient generated, and how do we really drive that information where it is person centered, where we're making a person have access to and share with data to the healthcare provider that they have ownership on. They can share what's important to them, that we can prioritize it in the care delivery we provide. That to me is interesting. And how do we start to figure out, is this a good measure for quality? So one of the things that Dave has been talking about, that Amy's been talking about, that we've been thinking about because of scope and how we capture patient-reported outcomes for spine surgery, right? I'm really curious. Is it data we should be capturing? Is this helpful? Is this going to help us provide better quality? Or is it another layer of data that we're capturing at the systems level, which require effort from staff, IT, from providers, from patients? It's really not going to move the needle on the care we provide. Should we do it? And so I'm interested now to really test these things at a bigger level that feels good, right? We should be capturing this information. Well, should we? Is it really going to drive the change? How do we actually make that actionable for healthcare systems, where it's not just one more thing we're supposed to check a box on, but it's one more thing that we're checking a box on because it really is improving patient care. So I think we're hitting that point now where we're really seeing this upswing, and I've been part of it. Oh, pros are great, they're wonderful, they're helping us drive care, but I think we're at the point now where we really need to test that hypothesis in different contexts. It may work really well in spine surgery, it may not work really well in, I don't know, in appendectomy, just because on the pick a body part that we're working on. So I think that's where I want to head with both pros and digital health. I will talk about the engagement piece in this context. I think that from the research perspective, having patients involved in how we design those studies is really important. I took the concept of PRO measurement to our Patient Family Advisory Council at UW Medicine, and it's a great group to just talk with about some of the initiatives that are happening at the systems level. And we were talking about this process of capturing information and incorporating it into care. This one woman said, I think this is great because when I was sick, the woman had cancer. She said I was in and out of the healthcare system in different departments for a good course of a year. And she said, I was constantly being asked these questions. And she said, over time, it actually made me feel more insecure about the care I was receiving, because I started to think, am I answering this wrong? Because it was so repetitive, and it didn't feel like her voice was actually being heard. So that every time she was being asked it, it made her think again, like, is everything good? Is this right? So that impact, that unintended consequence of wanting to capture information, can have a different different experience on someone's security of care and just continuity of care. So I think the engagement piece of how we set these systems up, be they for research or be they for health systems delivery, is really critical. Equally, and we talk about user-centered design in healthcare now, it's not just about patients, it's about clinicians and providers, and how do you make this data accessible. And so when we think about engagement for research, and so for the person who is interested in the research component, come find me, we think about who are the different stakeholders, and this transcends anything from marketing to healthcare delivery to research to just, I don't know, any form of design. Who are the different people that have a direct interest in what we're about to do? And of those people, what do we want from them? Do we want them to help us make decisions about the research we design? Do we need somebody from an administrative level who can open doors for us or who can actually make decisions versus just having conversations? Do we need people who have a direct experience with this condition or with this delivery system, be it at the staff level, the clinician level, the patient level, so that we can really understand the actual operational aspects of what it is we're trying to develop or intervene upon? And then, given the people that we want to include, who are we not including and why? And what are the risks of not including those folks? So there was a question, I think, Liz, you brought it up around diversity of care and how do we think about pros and patient-generated health data in across a more equitable delivery system. And I will tell you that's a huge gap and a huge area of need because a lot of PROs are developed in English only. Our systems are capable of administering them in English only, and that doesn't take into the cultural concept of, if we're asking these questions in this way, what does it mean for somebody that comes from a different cultural background? So I don't have a good answer for that. I think it's an area that we need to work on. We're not doing swimmingly well in English, but I think it's a huge area for care. So if you're developing these systems and you're not including people who come from different backgrounds or different settings, at what cost, right? So we think about who, the why, the what, and the how. How are we going to involve them in this process? Are they going to be advisors? Are they going to be key players in the design? User-centered design uses an iterative process where we develop something and we keep bringing it back and testing it and getting insight. And then how do we, how does that impact the work that we're doing? And so I think from the patient engagement, the stakeholder engagement, I think for both pros and digital health, be it for research or be it for health systems delivery, because those are two areas where my feet are now grounded. How do we engage all of these players in the system so that we can actually seamlessly implement, but then also evaluate in a way that is going to help inform decision making? So thinking about our PROs for spine surgery, is that a good quality indicator? Well, I need Dave to tell me from a health systems delivery standpoint, what is it that you need us to demonstrate for you to say, yes, let's keep doing this, or no, this isn't viable for me. And that's probably going to be driven by some of our insurers, our contractors. From a patient's perspective, is this informing your care? What are the unintended consequences of having access to this data? Some of our patients early on, when we were thinking about sharing PRO data back to patients, which we do, we share their information back. But we had this little tab where they could see how they compared to other people, and there was one group that said, oh, that's great, I want to see how I compare, and this other group that said, don't you even think about comparing me to other people, because if I look worse, I'm going to want to know what you did wrong, what I did wrong. So it's unintended consequences of sharing data because we think data is better. And then the other part of, well, where's that data coming from and how does that relate to me? So I think that there's a lot around the engagement piece that we'll have to think about to help people make it actionable in their own decision making, which varies when you look at the individual level up to the systems level. So that's kind of a high level pros, digital health, engagement. But what I want to hear about is either more questions, like what things do you think are interesting, things that you're thinking about in your own work. Ellie, I know you've been working on spine first with Amy. I know, Liz, you're going to be starting to get more into these things. You've been involved in the spine debut, those sorts of things. Julie, you've certainly been involved in Empower. I think you're coming on, Megan, to start dealing more. Shireen, yep. So what questions? Matt, I know you've been thinking about this in terms of some of the VI scope data, or just vascular in general and decision making. Francis, you've been looking at the engagement piece from small bowel and all the things that you're thinking about and learning about. What other questions, Sarah, you think about this in terms of all different aspects of pros on a regular basis? Any observations from your own work or things that you want to hear about? Dave, you can talk about pros too.
how is this allowing you to return to your life as you knew it before you had an aneurysm, you know? And I just, after spending 6 months working on the PROS project, it's like I can't not think about why aren't we asking that?
Yeah. Yeah, I think it's interesting. I think that it's this differentiation between, well, I asked that. I mean, I think from a patient to clinician relationship, I would be surprised. I don't know, Dave, Shireen, Francis, Matt, patient walks into the room. How do you typically start your interactions with them?
So I usually ask them, so I usually say, as you know, I'm a vascular surgeon, which means I work on your plumbing. What do you hope to get out of this visit today?
So you start with priorities, Dave. You?
You go right to insurance.
Yeah. What's your status?
I mean, the challenge with these big procedures is that it's hard to have a patient-reported outcome if you're not a patient anymore. So I think there are a lot of functioning on live dead kind of big procedures. But I mean, it's a missed opportunity to not engage patients about why they're having these procedures, which you're right, are often to improve function. Although Shireen, I think
They're to extend the life.
It's extending
It has
life.
nothing to do with function.
Right, and I get that part.
Although
It seems
quality of
like-
life extension is probably, if you're extending life at a cost of huge quality of life, and you're spending all that time in the hospital alive, I do think it's a missed opportunity, and it's narrow-mindedness on clinicians' part to think that they wouldn't ask these questions.
I mean, part of it is I'm reading like I'm in the clinic visit with the PI, and he's like, so how are you doing? How are things going? You know, just very casually. And some of that goes into the notes. You know, patient X is feeling better and has resumed walking and enjoys being able to pick up his granddaughter again. But that's not really something you can then take and compare against other people. It's a very casual observation.
And
And
I
we're
think-
only doing that really for the younger ones. The older, and by younger I mean like they're in their 60s. But some of the older patients, it's really just about being able to like, you know,
So two
still
things.
be alive.
So the disclaimer that I usually give them is, you at the moment have no pain from this. This doesn't cause you any pain.
Yeah.
The only pain that it does cause is the idea that you may die from a rupture.
Mhm.
So therefore, we're gonna take you, we're gonna put you through a world of hurt to repair this with the goal of extending life.
Yeah.
Like, that's a different perspective going into that operation as opposed to saying, my leg hurts, can you make it better?
But I think
Right.
some interesting parts about this too, and Megan, I know you have a point too, is expectation setting. Like where are you at now and what are your expectations moving forward? Then this other part that I think is really interesting around how we ask for information, and I think how are you doing? How are you feeling? What are you able to do is asked in different ways. So I do work in heart failure, and the thing that always struck me is when they would go, when somebody's in the hospital for a number of days and you have attending A come in and then attending B, they're asking these same questions in slightly different ways. And it's not anywhere but a note, which is not accessible because nobody reads the notes. And I say that in probably a more dramatic sense, but in a way that you can really look over a continuum. How have people been reporting these different aspects? For heart failure, how people can walk, their breathing status, those are the things that drive them to healthcare. That's what they've been told. These are the things to watch. But it's more anecdotal. It's not something that can be tracked and trended. So it really can be actionable. And it does allow you the ability to start looking back and saying, okay, how have you done over the past year that I've seen you? What were your expectations and where are you now? And given that you're not quite where you need to be, should we add some other aspect of physical therapy or other things? Because it's an important part of what you do day to day, but it's never captured in a way that you can actually turn it into something that says, okay, you're getting better, you're not getting better. Some of the folks in ortho say, you know, it's really interesting because people will come in and say, gosh, I don't feel good, but we can pull up their patient-reported outcome measures and we can say, no, but look, you are getting better. Like, you may not feel like it, but from this time to that time, look how much your pain has changed, or look how much your function has changed. So you're headed in the right direction. We don't expect you to be 100% until a year from now, so don't get frustrated. Keep up the good fight. So I think how you integrate that into conversations, into shared decision-making about, okay, this is, you don't have pain now, but here's what you can expect. Do you still want to do this? And even Gretchen Schwarze's work around thinking that there is this dichotomy of alive versus dead. There's actually worse than dead, which I never thought about until she told me. You know, worse than dead is you have a complication, you end up in a nursing home, and you die there. And so how do you start to put this context of what's important to people? This isn't about what your plumbing will look like, but really how you function around that. And it's part of what we do. It's just not accessible in a way that we can actually look at care. The other thing I think is really interesting about PROs, and I think this is something that just came to me from another provider. Well, I don't want to capture those because this is in advanced heart failure. They don't get better, and this fear that I'm going to be judged that they're not getting better. So how do we start to set expectations that you have a chronic progressive condition? I have a girlfriend with MS. She knows it's not going to get better unless they find a cure, and God hope they do. You're going to get worse over time. This is what you can expect. This is what we're going to do to try and keep you above the threshold. But it's not about, you're wrong or you're right or you're doing something wrong. It's about health in general and how it changes over time. So how do we start to change the conversation? This is a new piece of information that we can share. It's probably more tangible to people than a blood pressure reading. So anyway, Megan, you were going to say something and I went off on a tangent.
I guess I was just thinking a little bit about the role that the clinical data actually plays in driving like future plans. And, maybe with this condition, people, if there isn't actually a lot of even just capturing, living like just regular function, just capturing the EMR. But, maybe it has to be at that point first before the physicians even have a point of, okay, let's actually talk to those patients. Because also just thinking about the other like scope, VI scope, spine scope, that there was some of that data already collected and then we added on those extra levels.
Yeah.
So what's the time frame, I guess, in that? Like, at what point do you feel like you just pick a disease and you can go and say, let's go get patient-reported outcome, or like what is like the background of getting to that population?
Yeah, I think SpineScope is a good example of that in terms of PROs weren't being captured at all. And in a lot of cases where they're not being captured at all, there is at least a 2-year time frame, and it depends probably on the volume of patients, where we have enough data to really look at and say, okay, now what? And I think that the PRO data for spine has just hit this point where we can really look at it in a manner that says, is this a good quality metric, right? We're just doing some of the baseline, and this is the baseline, like everybody seems to be performing the same, so is it a good quality metric, or have we never really looked at it and displayed it in a way that people actually want to improve on that specific metric, right? So I think that it's an interesting piece because we are literally building the ship of implementing PROs in an enterprise fashion where we can capture this information across all people, but it'll still be, I think, another 2-3 years before we can really evaluate, is it improving care? I think, I don't know, I mean, some things are probably more straightforward. Depression, for example, that's our only blood pressure of, is your medication working or not? I think that's an accepted clinical measure, but as we scale and spread across systems, or we look at clinical conditions specifically, I think there's still time to determine, really, is this a good idea or a bad idea? Dave, I don't know if you have a different perspective on that, thinking
Well,
from...
so I had a little bit of an aha moment with Sarah Core on Wednesday. Well, she probably doesn't think this is the aha moment because I was horribly distracted and driving, but it's a huge thing that she found. The depression thing you should all know about, because I think it's one model of how you can, like a vital sign, totally change the way we reduce suffering.
Is this like
We've been
PHQ-9?
taking care of people with depression forever in the healthcare system. We do a shitty job at it. In part because we have no measurement of how they're doing. We lose track of who we put on meds. We hope they're doing okay if they don't come back. More likely, as often they're not. Although that only about 1 out of 2 people who put on antidepressants ever gets a medication adjustment. Yet the meds are all about medication and also other adjustments like psychosocial health, supportive care, and all that other stuff. Just simply adding a regular PHQ-9 measure, which is a measure of depression, all of a sudden gives people involved in behavioral health some sense of, are their patients getting better? And one thing, as soon as you show people their patients are not getting better, they can act on it. For the first time ever, just last month, I saw that our rates of sort of cure of depression gone from like 3% to 30%, because we're showing docs and teams who's not getting better, and they're changing medications and doing everything they're supposed to do. And that's a really good example of PROs driving care because it's measuring something important